So our next speakers this morning are going to be Dr. Carpenter and Katie Buca, who's a pediatric nurse practitioner, and they're going to be presenting on craniofacial conditions. So Dr. Carpenter is a craniofacial and plastic surgeon. She received her medical degree from the University of Massachusetts Medical School and completed her residency at Montefiore Medical Center and a fellowship at Albany Medical Center in Atlanta. Dr. Carpenter is bilingual and practices at Gillette locations in St. Paul and Burnsville. And she's going to be presenting with Katie Buca, who's a pediatric nurse practitioner. She attended nursing school at St. Olaf College and completed her master's degree at St. Catherine University. Katie joined Gillette in 2008 after obtaining her pediatric nurse practitioner certification in 2014. She joined the Craniofacial and Plastics team, and Katie sees patients in St. Paul, Mankato, and Maple Grove. So I will let Dr. Carpenter and Katie take over. Thank you, guys.
Thank you. I'm going to try to share my screen. Hold on just a second. All right. Can you all see the screen?
Yes, you're good.
Great, fantastic, thank you. So I'm Courtney Carpenter, and Katie Buca is going to be doing a separate presentation afterwards on hemangiomas. And I'm going to start, we're going to change direction a little bit, and I'm going to be talking about craniofacial and pediatric plastic surgery. And as the title of the presentation implies, the objectives of today is hopefully you'll be able to describe what pediatric plastic surgeons can provide for your patients, what services, and hopefully when to appropriately refer them, because the success of the treatment quite frequently depends on if they're sent to us in time. So first, what does a pediatric plastic surgeon treat? I can't tell you how many times I discovered when I started my academic practice in New York that my colleagues, my surgical colleagues who I worked with alongside in the OR every single day, had absolutely no idea what I was doing. You know, you say plastic surgeon and everyone thinks that you do cosmetic surgery. And so you say you're a pediatric plastic surgeon and you kind of get scrunched faces and people you can see are questioning your ethics. But 99% of what we do is reconstructive in nature, and cosmetics isn't any part of it whatsoever. So when I try to describe to people what we do and what services we provide, I pretty much tell them that plastic surgeons can take care of any kind of issue, starting from the head all the way down to the feet, in terms of the soft tissue. We also handle bone of the hands and the face and the head. We treat people all the way from prenatally, I mean, obviously not the actual baby at the time, but we will consult patients once they have a prenatal diagnosis. Parents get these diagnoses at their 20-week scan, and then they have 20 more weeks to stress and have high anxiety about the issues that they've now been told their baby has. These are usually the bony structures, which can be seen in the ultrasound, so any type of hand and upper limb issues, or most commonly cleft lip and palate. Once the baby's born and they turn into children, we take care of traumas, burns, any type of lesions, of course, like I said, the hand and the face, also breast, and we do a lot of wound care as well. The things that we don't treat are inner ear, larynx, and genitourinary. And I wanted to add, we also don't handle the globe of the eye. We do eyelids, but we don't do the actual globe. And we use that to our subspecialists. So this is by no means a comprehensive list of things that we take care of, but it is kind of split down into things that we need to see sooner versus things that we need to see later. Head shape concerns are things that we would want to see much earlier than later. These can be caused by Craniosyostosis, Plagiocephaly, or Torticolis, and I'm going to go over those. I'm going to go over actually each of these things individually throughout the presentation. Cleft lip and palate, I already mentioned. Hemangiomas, Katie Buca is going to be going more into detail during her presentation. But those polydactyly and ear molding, we would need to see pretty much within the first couple weeks of life in order to be able to appropriately treat and have a higher success rate of the treatment. Things that we definitely treat, but we can deal with later in life are dermoids, benign skin lesions, syndactyly, trigger thumbs, capillary malformations, and then breast issues such as gynecomastia, macromastia, and Poland syndrome. So we're going to start off with the head shape anomalies. Benign positional plagiocephaly has to do with the shape of the skull due to external forces. So when you think of the shape of the skull, it's really a kind of like a battle between internal forces and external forces. Internally, the head is shaped by the expansion of the brain. So the brain growth stimulates skull growth. The skull grows at the suture points. Those are growth centers for the skull. And then you have the external factors, such as the external pressure. So you have the brain, which is expanding out. And then say, for instance, you have a baby, mom has 2 other young children that require her attention. The baby's perfectly satisfied to be sitting in a car seat all day long. So that's where she leaves him. He's laying on his head all day long. And so you get the flattening in the back of the head. And now you can imagine that child preferentially looks to the right, and then you get a different type of head shape flattening where it's more on the right side, but that also causes the forehead on the right side to bulge out. It causes the ear to shift, and that's where you get benign positional plagiocephaly. Some other external factors is the muscle tension on the skull. You have the sternocleidomastoid muscle, which inserts at the mastoid behind the ear. And when this is fibrosed, you have torticolis. This causes, there's less flexibility, so the child cannot tilt the head to the opposite side. You can't turn the head to the opposite side. And so there's a preferential head tilt. And you can imagine that with the preferential head tilt, they're lying on one side more often than the other side, and then you get that flattening. Now, this is something that can be resolved. It's usually resolved by physical therapy, and the earlier physical therapy is instituted, the higher chance you have of correcting this. If physical therapy, in the uncommon instance that it doesn't work, which does happen on occasion, then we can surgically intervene at the appropriate age and surgically release that muscle in order to get the head back up. But by instituting physical therapy early enough, you can hopefully prevent the plagiocephaly that comes from having the head tilted to the side all the time. And then we have craniosynostosis. As I'm sure you know, this is premature fusion of the sutures, one or more of the sutures in the calvarium. As I mentioned before, the sutures are the growth centers of the skull. So once that has fused, which most of them in an average skull fuse in the people's mid-20s. So when it fuses early, it doesn't have the capacity to grow in that area. And so the other sutures continue to grow. It's not growing in that one fused area. And that's how you get this pathognomonic head shape. I don't know if you can see my cursor, but down here in the lower right-hand corner, they show deformational plagiocephaly, and you can see that all of the sutures are open as opposed to each one of these where one of the sutures is fused, but you still have that head shape. So you can see how it can be very difficult to make the diagnosis just based on head shape alone, but that's where we come in as craniofacial surgeons, and we can help make that diagnosis and then the appropriate treatment afterwards. So just to review some of the head shapes, the sagittal craniosynostosis will give you a very elongated head shape, which we call oat-shaped head. You get the bulleting of the posterior aspect. Here's the patient's face, and here's the back of their head. So you get the bulleting in the back, and then you get the bossing of the forehead in front. And then if it goes undiagnosed long enough, you actually get a dip in the middle of the calvarium called a saddle-shaped deformity. For unicoronal craniosynostosis, it's best seen at a bird's eye view or a worm's eye view. You can see the flattening of the forehead. And generally, this presents by a parent coming in and saying, I have my kid has one droopy eye, and is this a problem? What's going on? Can this be fixed? Well, that's actually the normal side, and it's the side that's affected that has the wide open eye. The coronal suture, which sits right about here, isn't growing, and so the rest of the head is growing out, and this bone, because it's not growing appropriately, you can imagine it's kind of pulling up on the orbit and causing the eye to be more wide open. Metopic craniosynostosis can be confused with a benign metopic ridge. So the metopic suture right in the middle is the only suture which fuses normally early in life, and it's usually between 2 and 4 months, but it can be normal for a baby to be born even with it fused. And usually when it fuses early, you will get kind of like a ridging down the middle, but that's not a surgical indication for intervention. When you want to intervene is when the fusion causes this triangular shaped head that you can see from the bird's eye view, and that causes there to be less protection of the orbits on the lateral aspect. And there is about a 10% of learning delays in these patients. And so we want to get in there and really open up the forehead space for the brain to grow. And last, we have lambdoid craniosynostosis, and this is the one that's most often confused with benign positional plagiocephaly because it occurs in the back of the head. There are some very subtle differences in the head shape. Most commonly, the position of the skull base in benign positional plagiocephaly, it continues to be flat, whereas in lambdoid craniosynostosis, you're going to see kind of a crooked nature. The ears also would be up and down instead of just front and back in terms of malpositioning. And again, very difficult to diagnose just by physical exam. We can easily scan children even within the same day of their appointment. So it's significantly easier if you refer them early for us to help with that diagnosis. So to review all of these, positional plagiocephaly, craniosynostosis, and torticollis, every single one of them is best to be referred early than later. In terms of positional plagiocephaly, the ideal time for getting a child into a helmet is about 4 months old, and this is when they have great neck stability, head control, they can tolerate the slight excess weight of the helmet, and it really allows for more time in age of growth potential of the head in order to help mold. If you get a child into the helmet at like 6 months, 7 months, the head isn't growing as rapidly, and so it takes longer helmet usage for that head shape to change as the child grows. Torticollis. As I mentioned before, the earlier you can intervene with physical therapy, the more likely that they will avoid positional plagiocephaly and not need a helmet. But if the physical therapy isn't enough, they're already established in our system, we can get them into a helmet. Or if it doesn't work, they're already in our system and we can get them set up for surgery. In terms of craniosynostosis, some of our surgical interventions we actually perform at 2 to 3 months of age. So you can imagine if it takes, a couple days to get the appointment with us, and then we do the workup, and then we have to set them up for surgery. A safe timeline would be seeing us a month before the surgery. So really, we'd want to be seeing them no later than a month to 2 months of age. If we want to intervene surgically. Now, if they do come to us later than 3 months of age, we can correct the craniosynostosis as well. We perform a surgery around 9 months old. But the surgery performed earlier in life generally has less blood loss. It's a shorter operative time. There's less swelling. There's a shorter operative stay. So all in all, it's kind of better and less onerous for the patient. So getting them to us so that we can evaluate them if they need surgery earlier is significantly better than later. On to cleft lip and palate. As I mentioned before, we will see the parents in the prenatal time period. I can't even count how many times I had a patient, a mother sent to our office. She gets a diagnosis at 20 weeks. She comes to me several days or several weeks later. She's been unbelievably stressed. She's in my office crying. She's been crying since the diagnosis. And all it takes is one educational session, and they will actually leave smiling and saying, I feel so much better. I actually feel like my child has a chance. Most parents are concerned about feeding, whether their child can eat when they're born. You see a lot of scary stuff online, so they try to do research themselves, and all they see is horrible images. And so once they come in, they are significantly relieved of a lot of anxiety. So we will see them as soon as they get a diagnosis. We here at Gillette, we are an ACPA certified clinic. That's the American Cleft Palate and Craniofacial Association. It's a multidisciplinary team that is dedicated to cleft care. When parents hear that their kid has a cleft, they think, oh, one surgery and they're done. And it's not. It is a lifelong journey, but the majority of it takes place from birth to early adulthood around the age of 18. And it is comprised of all the people that you see listed here. All of these people are involved in our clinics. So when a patient comes, they see everyone that they need to see all at once. They don't have to be sent to another clinic. They don't have to wait for another day. They don't have multiple appointments. But every appointment that they have, we have all these specialists available to them. And this is a data-driven model of care. It's been proven that patients who are taken care of in multidisciplinary clinics have better outcomes and are significantly happier with their care. And this is a very general overview of the types of interventions that kids have from birth through early adulthood. So as I mentioned before, we will see people in prenatal counseling. And then at birth, the first thing that they have is feeding assessment and nutritional education. A lot of times it does just take education and teaching moms and dads how to use this specialized bottle to feed their child. And another thing that a lot of people don't know is that kids with clefts can breastfeed. If they're not able to breastfeed, it might just be, kids without clefts can't breastfeed also. So it's not a cleft that is necessarily preventing a child from breastfeeding. Early in life, they get a lip repair, a palate repair, and usually ear tubes. And then in the toddler years, the focus is on speech. As they go into childhood, orthodontics gets involved. They need another surgery for bone grafting. And then in the mid to late teenage years, a lot of people end up with some orthognathic surgery, and their crowning surgery, the last surgery they have usually is a rhinoplasty, which will end up their treatment. But this really is, and that, like I said, is around the age of 18. So this really is a lifelong journey. And all of the specialists that I listed in the previous slide are involved throughout this entire timeline. It's just that some of them are more prevalent at certain age groups than other times. So moving on to hemangiomas, like I said, Katie Buca is going to be giving a more in-depth presentation, but just in general, these can be present at birth, or they can show up very, very shortly after birth. And they have a very quick and intense proliferative period. They can occur anywhere on the body, and the involution phase is usually significantly longer. Now, the treatment of hemangiomas is the medical treatment of hemangiomas, which is the first line of treatment. A lot of people think surgery is the first line, but it isn't. But the medical treatment is best instituted before 3 months of age, because that is really during the growth phase, and that's what we're trying to stymie. So once you see that a patient has a hemangioma, sending it to us as soon as possible, it will give the highest success rates for treating this child. Polydactyly is something that can occur on any of the digits, both hands and feet. It can be, the middle digit, the thumb, anything, but it is most commonly on the 5th digit on the outside. Again, it can be anywhere from this teeny little stalk to something completely more robust that you see here on the foot. Now, if it's something simple, like a little skin bridge here, this is something that we can remove in the office. Way back when, and even some people now will tie them off, but that is not something that we recommend because that usually leaves a little teeny bump on the side of the finger and the nerve grows into there and causes a neuroma. And that neuroma, every time they put their hand down to sign a check, eat dinner, anything like that, it can cause this shock, which goes up their arm, and it's painful, and it's something that people will seek surgical correction for later in life. So we just take care of it right away and excise it properly the first time. So this is something that we can take off if it's within the first couple weeks of life. Once it gets to be older than 3 months, we tend to wait and do it in the operating room, but that will subject them unnecessarily to an anesthetic, which could have been avoided if they had come to the office sooner than later. Ear molding is also something that we need to see probably best suited within the first 2 weeks of life. Babies have some circulating maternal hormones in their bloodstream that do kind of fade away by 6 weeks. And those maternal hormones can keep the cartilage nice and soft and moldable. As soon as those are gone, the cartilage hardens and there really isn't much we can do. So one of the things that is highly frustrating is, you know, a family comes in, they have a newborn, the baby's 8 weeks old, and they got some ill-given advice by a neighbor that they should wait to see if they grow out of this ear deformity. And at this point, it's too late. There's not much we can do in terms of molding. And it is something we can take care of in the future, but it's going to require, again, surgical correction in the operating room. So sending these babies to us as soon as possible is will give them the best treatment. And now we're going to be moving on to a bunch of things that we take care of, which are not so vital to send immediately. We do take care of even early in life, but you know, we can see it 6 months or a year or something like that. The first one's dermoid cysts. Mom and dad usually see it frequently after birth. The most common area, about 80%, is in the head and neck area, but the very most common area is the lateral brow. We do see some midline, and when we do, we get imaging for those children because there can be a stalk which goes straight down to the dura, and that is actually a little pocket of CSF, and the last thing we want is some CSF leaking from the child when we perform surgery. So we will get imaging on those just to make sure there's no connection down to the brain. But otherwise, this is something that's very quickly done in the operating room. We do try to wait until the patient is around 6 months or a year because there's really no need to unnecessarily expose the little growing brain to anesthetic when this is not something that's an emergent situation. American Academy of Anesthetics, I believe the official recommendation for elective procedures is waiting until 4 or 5 years of age. Most parents want these things taken care of before 4 or 5 years, and since the surgeries are very quick, we do them as young as 6 months, but we do encourage waiting if it's okay with the parents. Again, benign skin lesions, something that we can deal with later in life, and if the parents are okay with it, they can, you know, we can do it as a young teen or in the office without subjecting them to any anesthetic. But if they want it taken care of ahead of time, you know, we can do surgery, laser treatments, but again, we're not going to do it any earlier than 6 months to a year. Syndactyly can be both on the hand and the feet. It can be anywhere from an incomplete to a complete, all the way down to the tips of the digits. And it can be anything from what's called simple, where it's just skin involved, to complex, where there's actual bony fusion. For these, we wait until a minimum of a year. The structures of the hand, the nerves, and the arteries that we're trying to preserve, which run along the sides of the digits, are extremely small, younger than a year of age. And since we're trying to conserve those, the older they are, the better. At 1 year, they still don't have the dexterity of their hands, and their function isn't going to be affected by being fused together. So we do wait until at least a year to correct these. In terms of the feet, we don't necessarily encourage separating fused toes unless it's between the first and the second toe, and we will do those so that the child can wear flip-flops, but otherwise, the other digits we tend not to encourage because it is a kind of an onerous procedure for the parents to deal with, the kids to deal with. There's a very low satisfaction rate, even though you can repair the syndactyly all the way to where it should be. Over time, it tends to creep up, and it's almost back to where it was when you had the surgery a couple of years later, and that can be very unsatisfying. So, like I said, we will do between the first and second toe, but we don't encourage a separation of the other toes necessarily. We do a lot of scar revisions. Obviously, keloids and hypertrophic scars people think are unsightly and want revised. If a child has a trauma, a dog bite, a fall off a bike, and they have a scar on their face and they want it revised, and it happened 2 months ago, just know that it's standard of care not to revise scars for a minimum of a year till after the injury, because scars will revise on their own for a year to year and a half. And you can send them to us and we will give them tips on scar optimization, but we won't intervene surgically until a year, because scars can revise drastically in that time period. And sometimes people just end up saying, this actually looks good. We don't need surgery. I do see a fair share of teenagers who, when they were preemies and they had X-laps in the NICU, or they had G-tubes, and then they get this scar where their skin is tethered down to the fascia underneath. And these are actually some of my favorite surgeries because they're super simple. And the patients are so happy afterwards, relieving that divoting. And so we'll see patients for that type of scarring as well. Malformations and port wine stains can show up anywhere on the body, but they are most frequently seen on the face. They do vary in size and color and intensity. It's not necessarily something that bothers people when they're younger so much as when they get older, because over time these port wine stains will become very thickened and they become bumpy, and people tend to not like the look of it as they get older. So there are some things that we can do to intervene when they're younger before it becomes this way. There is laser treatment. It's a series of treatments that we just do depending on the child and how it reacts to the laser. Again, it has to be done under anesthesia, and so we're not going to intervene until the child is at least 6 months to a year. Trigger thumb is another common childhood thing that we treat. It's where the thumb is kind of stuck down or pops when it flexes and extends, and it's essentially due to a kind of like a nodule or a swelling of the tendon. It's an anatomic nodule that prevents it from sliding under the A1 pulley. It's not recommended to force the kid to pop it back and forth. Repeated motion like that can cause irritation to the tendon, and it will cause swelling, and it'll cause pain, and it will make it even more difficult to go back and forth as time goes on. This is something that's easily treated by surgery. You just make a very small 1 centimeter incision at the base of the thumb and cut that A1 pulley so that the tendon can slide without any type of obstruction. Again, because the hand is so small and all the structures are very delicate, we don't want to damage any of them. We do like to wait until the child is at least a year old. Stress reductions are something that sometimes people think are a little bit controversial, but again, I assure you that this is done for medical purposes and not for cosmetic purposes. There are adolescents now more and more every year who have very, very large breasts, and this causes significant problems for them. We do prefer to wait until the breast growth has stabilized, and we do work with the pediatricians in order to decide when that is. But we do this on a case-by-case basis, and these these young women have incredible lower neck pain, upper back pain. They have a lot of social issues because of their large breasts. A lot of them can't exercise. They're in pain all the time. And those are the reasons why we do offer breast reduction to these young women. And it does have a significant impact on their quality of life. It's one of the few surgeries where my patients will literally come back to me and say, "This has changed my life. Thank you so much." It is kind of difficult to get it approved by insurance, and that's where we look for some collaboration with our pediatrician colleagues. It requires documentation that they've tried some conservative management first. We need documentation that they have neck pain, back pain, shoulder pain, that there's grooving from the bra straps, that they have rashes underneath their breasts that doesn't resolve with powders and treatments. There has to be documentation that they've tried weight loss, which, by the way, never works to alleviate their issues. But it still needs to be tried and it still needs to be documented. And a lot of times they require 6 weeks to 6 months of physical therapy as well as medical treatment with non-steroidals. So these are the things that we look for when the patients are sent to us in order for us to be able to get it approved by insurance. And here's just an example of the types of patients that we take care of. This was a 13-year-old child that Dr. Barta operated on, and you can imagine the pain that she has. When breasts get this large, it actually changes your center of gravity. And when the center of gravity is changed, it causes strain on the upper back and the lower neck. And then when we do breast reductions, it's not only making them smaller, but it lifts them up higher on the chest, and that restores the normal center of gravity so they can stand up straight and they don't have that pain all the time. And we don't make people so small that they're disproportionate. We try to keep people proportionate to their body size. And this, of course, comes with a lot of counseling, both to the patient and to the parents. We counsel them on scars, we counsel them on potential complications, we counsel them on future breastfeeding, which, for those of you who don't know, with a breast reduction, you can still sometimes breastfeed. It's not a guarantee, but it is definitely documented that breastfeeding is possible. So these are the types of patients that we will see and do breast reductions on. These issues are not for women alone, unfortunately. Men also have breast issues. And again, these have to be well documented in order to get approved by insurance. For gynecomastia patients, they frequently require an endocrine referral first. I mean, either you could send them or we could send them, but it is going to have to be done at some point. And well-documented history, noting that there are no medical reasons for them to have breast hypertrophy either. In men, this is either due to an excess of fatty tissue or an excess of true breast tissue. And quite honestly, the majority of times it's both. And we do have a variety of ways of reducing this for men, including just direct excision, liposuction, and again, documentation in order to help with us getting insurance approval. Poland syndrome is a congenital absence of several anatomic structures, most notably the pectoralis major muscle, but more distressingly, it can be an absence of a nipple, it can be an absence of the entire breast, as well as hand and upper extremity abnormalities. And so we will do reconstruction on these patients, including implants, expanders, whatever it takes, the patient-specific issue. We do these later in adolescence when the other side has stopped growing, and sometimes they even need a symmetrizing procedure on the other side. But these can be quite distressing because it's it's congenital. It's right around the time when children are so self-conscious, and so we do these types of issues as well. Something that I didn't put in these slides is a tuberous breast deformity. That is also not necessarily uncommon in society. And for those of you who don't know, it's essentially like a very constricted breast. It's almost like a tubed sock hanging off of the chest wall. And we do take care of that as well. So to just generally review, the things that you want to send to us sooner, and sometimes even within the first weeks of life, you'd want to send head shape concerns so that we can help diagnose and treat appropriately within the first couple months if it's noticed. Cleft lip and palate, we will even see that prenatally. Hemangiomas, polydactyly, and ear molding within the first couple weeks of life for the best success rates in their treatment. And things that we can see later: dermoids, benign skin lesions, syndactyly, trigger thumbs, capillary malformations, and any type of breast issue. This is our team. My partners, Dr. Barta and Dr. Lacey, and we are all board certified plastic surgeons, and we all have had additional training in craniofacial and pediatric plastic surgery. So we had an entire year dedicated to learning how to completely treat cleft care and craniosyostosis. And then we are joined by our wonderful nurse practitioners, Katie Buca, who will be presenting to you next, Martha McGrory, and Anna Rausch. And we do practice in St. Paul, Maple Grove, Burnsville, Mankato, and soon we'll be going to Duluth to be able to bring our services up there to that area. I provided contact information for our administrative assistant and our clinic nurse, so please feel free to reach out if you would like to make any type of referrals. And Dr. Barta and I, here is our contact information in both our email and our personal cell phone numbers. We neither of us mind phone calls at any time for any question whatsoever, whether you should refer, you don't know what you're looking at. We'd love to speak to you, meet you, be in contact with you. So please record our information and give us a call. Thank you.